Hello, my name is Gary Belkin, and I am the Executive Deputy Commissioner in the New York City Health Department. I oversee our mental health work. It's really a pleasure to be able to speak with you on what are doing here in New York City in our approach to addressing mental health called Thrive NYC, which in a nutshell is really looking to work to change the relationship between local government and mental health. I really wish I could be with you, but I've had the additional pleasure recently of having a second son arrive in my life a few days ago, so I can't be there. We have learned much from our colleagues in Sweden, and especially Frederick Lindenkrona and his team, so it's gratifying to give a bit back and describe briefly our work to challenge and flesh out the unique fit, I think, between local and regional government position and a needed new model of mental health policy. And by doing so, if we get that right, I think we'll also get to a more complete model of social policy. So we build off two things that we know. First, we know accumulating evidence around the world underscores the wide and deep impacts of mental illness and mental health on social outcomes, on overall health, on premature mortality. We estimated 1 in 5 New Yorkers meet criteria for a mental illness each year. And depression alone is the leading contributor to disability in both of our countries. These facts translate into real burning realities: kids not graduating from school, families not staying together, people losing jobs, the social fabric of our communities frayed. We decided in New York City that we needed a mental health strategy that lived up to this reality, that recognized that if mental health and the impact of illness was so broadly everywhere, then we needed a response that was everywhere and put more skills and capabilities in places outside of the mental health treatment system, in schools and houses of worship and primary care and daycare and neighborhood groups. But to also support that treatment system to be a better partner in those places and more openly accessible to those places. It meant looking across the population for where the key burdens and risks were and the multifaceted approaches to meeting them that arise from taking that point of view. Really breaking what, at least on our side of the Atlantic, have been longstanding habits in mental health policy to really focus on just certain high-risk need groups or on favorite programs of the moment, rather than on looking for cross-cutting structures and key strategic directions that are needed to meet the needs of a public health approach. We basically made the case: if mental health and substance use represent a leading public health challenge of the 21st century, then we have to act like it. So the second thing we know is that there are way too few scaled examples of how to act like it. How does one go about such a broad change and such an agenda? In one sense, the way we scoped mental health as an issue caught wide attention and support quickly among elected officials and across agencies and across different kinds of stakeholders, I think because it was scoped big, because it was speaking to and adding to and bringing solutions to the larger challenge of governing for the well-being of the population more broadly. It revisited assumptions about and generated a more expansive and participatory understanding about who is a part of the so-called mental health system in order to make something like this public health vision work. This led to a process of broad stakeholder input that generated and refined 6 key principles that we identified that describe the areas of activity that could drive the range of change we needed and were especially well matched to what we in the city, what local government could do or lead. In particular, calling on multi-sector collaboration and engagement of the sort that local government knows and convenes better. So to give you a flavor of what I mean, let me walk you through these 6 principles. Change the culture, act early, close treatment gaps, partner with communities, use data better, position government to lead, and some of the initiatives that were derived from each of them. Now, all of the initial 54 initiatives of Thrive NYC and their initial 4-year estimated cost of about $800 million fall within one of these six, or derive from one of these six key new directions of change. And we try, for the most part, to identify initiatives that both exemplify the intention of that principle and give it some real-world reality of where we want to go, but to also intentionally use that new reality to try to drive more of it, further similar change. That's why the strategic six-principle framework is so important, is to keep us honest about where we're headed and why we're putting these things in motion, and that they're not one-offs. In that sense, many of these initiatives were designed to not just be, again, a useful program, but a disruptive one that represents the kind of structural change that could reverberate and spur ongoing movement in the intended direction the principle lays out. Thus, Thrive NYC can be most briefly summarized then as a principle-driven public health approach, where these initiatives were at least intended as platforms as well as programs. So let's change the culture. Here we meant that a key lane of change to build into the work of the city was to not only address biases and stigma and grow a sense of normalcy and comfort around mental illness issues and of all ranges, including the most seriously mentally ill. One key example of an initiative here is to train 250,000 New Yorkers in mental health first aid. But we also saw, as part of Change the Culture, to really change how behavioral issues work in key institutions. So taking on, for example, school climate, enlarging the attitudes and the toolkit of policing to act in more public health ways when encountering people with emotional disturbance. In that case, we're training all of our patrol officers in crisis intervention training and making that just a part of our police academy. Second principle, act early, reflects the need to really catch up with neglected underinvestment in things we know work in prevention, especially in building early year healthy attachment, secure emotional bonding, and self-care skills that are really the tracks laid down in early childhood experiences for ongoing mental and other social health. So, for example, to make that the new normal, we're aiming to provide socio-emotional learning skills to all of our public pre-K and daycare staff, which means an aspiration of having 9,000 staff with the skills to build in better these early skills in the children's under their charge, touching about 100,000 kids a year. And supplementing that as well by constructing a network of clinics that specialize and provide technical assistance, including coaching to parents and staff in their settings in early child mental health. Third principle, close treatment gaps. There's a lot we asked ourselves here. Can we close gaps in access, but also in quality, efficacy? And can we close the gap between the brief view that providers get of the few people who happen to come to them versus the view of a map of the unmet needs of the communities outside of their offices? That is, can we connect the treatment system to population aims and objectives? That raises a whole bunch of interesting opportunities we're pursuing, such as what is the right role for new developments in app and web and other cloud and digital-based access solutions that remake everything from getting more people tools to support their self-care to scale direct access to a therapist. We also targeted certain key high-impact treatment gaps that we decided we were going to intend to close. For example, getting to universal screening and treatment for pre- and post-partum depression through a voluntary 30-hospital system learning collaborative, where talk about, again, not just building a program, but building a structure. We've built the capacity to provide a foundation of quality improvement methods to support these systems to achieve this goal around maternal depression, but now a capacity that we're applying to achieve other goals with communities and with health systems. But our most probably disruptive approach and to close treatment gaps principle was to advance something called task shifting or task sharing. This is the idea that now growing evidence supports that many of the skills that are part of mental health promotion pathways or initial steps in treatment pathways can be proficiently and often more consistently and credibly provided by non-specialists by clergy, teachers, community health workers, peers, parents, thus markedly diversifying and spreading access and opportunity, as well as relatably credibility and local ownership and use of these interventions and this work. These people and places are often those that see and reach people first and most effectively, who are laboring with mental illness or managing traumatic experience and toxic stress that may not meet the threshold of a diagnosis, but are highly damaging over time to health and social functioning. Yet these places are not equipped to be the front lines for mental health that they actually are. So we're testing the idea of partnerships between them and mental health providers, where a role of the mental health provider is not primarily to treat, but to coach, mentor, and build the capacity for these other places to act, engage, and counsel. Our next key principle is partner with communities. That principle really recognizes that communities, neighborhoods, have to be supported to be places that support mental health promoting places, and that they contain the resources, wisdom, insights, ideas to innovate and be effective, and so need to be treated as those kinds of partners in developing place-based solutions. Social ties and social isolation, built environments and social environments, local factors in quality of life and collective efficacy, impact, risk for mental illness, the ability to mitigate, prevent illness, and promote recovery, whether it's common disorders or the needs of the much more seriously mentally ill, alike. So here we also can see examples of how our overarching principles, and thus at our ground level, our specific initiative strategies, synergizing and fueling off each other as intended in structural ways. So for example, a commitment to task shifting is a perfect opening for broader community involvement and partnering, often assisting by our change the culture efforts. So for example, in trying to really engage communities to act with us around bringing more folks into the system through task sharing, we find our mental health first aid efforts can be a great front door to mobilize local action and interest in voicing community needs and advocacy. We're increasingly convinced that structures and tools for community-led action and opportunities to focus, thrive, and other assets to enhance that action is where the proof of our strategy will get its best tests, its best opportunities, its best likelihood to be sustained and used and deeply embedded. And so we have several efforts intended to also use learning collaborative and similar methods to build tools and community support platforms that make this potential real. The next key principle is to use data better, which recognize that to do all that I've discussed needs new, more nimble, real-time, actionable, geographically precise data, which we don't have. So we need to explore how to create other data sourcing options, as well as network and forge collaborations through something we are calling and about to launch an investigators hub to take advantage of forming more of a network of interest and opportunities that our initiatives can generate new data and ask new research questions by building out a research community. And finally, the last principle, build position government to lead. To do all this, government has to lead. But to do all this, government also has to change. It needs new skills, new methods, new structures to bring in all of government. The paths these initiatives have started to set need the work to be embraced by other sectors, if not mostly other sectors. Schools, police, community actors, etc. So we established under a mayoral executive order a New York City Mental Health Council, which brings multiple agencies together to harness all the ways they touch New Yorkers and to work together in those ways on shared aims to promote mental health and close gaps for illness. So I'm going to close on that last point. This broader sense of mental health not only finally realistically calls out the true scope and scale we need to aim for and the relevance of these issues across policy domains, but starts to reinvent, as we must, to realize that, how we imagine the mental health system and the opportunities for government, especially local government, which knows its neighborhoods better, is better at doing cross-sector and multi-stakeholder work to drive that imagination into reality. Doing so is not only important for long-delayed attention to issues around mental health, but to engineering a more effective social and health governance overall, and to give actionability to the hope of promoting well-being for our citizens. It's been a pleasure to talk to you. I'm sorry I can't have an exchange. I hope your meeting is fruitful and that this has been useful. Thank you very much.